Hello, everyone. Welcome to my talk today entitled Thyroid Disease in the Elderly Person. I have no conflict of interest to disclose. So we have a few objectives today. We're going to discuss hypothyroidism in the elderly, how to recognize some of the symptoms and make the diagnosis, how to manage hypothyroidism effectively and safely, controversies in diagnosis and treatment in the elderly. We'll also talk about hyperthyroidism in the elderly. We'll discuss the clinical presentation, etiology, diagnosis, and management. Finally, we'll end with a few words on thyroid nodules. So we're going to start with a case to get your wheels turning. We have an 82-year-old female with hypertension and arthritis who complains of fatigue, constipation, and muscle aches. Her blood pressure is 128/86 and her heart rate is 68. She's a well-appearing, thin woman who walks with a cane. Her thyroid gland is palpable on exam. She has no thyroid nodules. Her cardiopulmonary exam is normal, reflex is intact. She requires use of her arms to rise out of the chair. So you check a lab panel and find labs are normal except for a TSH that's elevated at 24.1. What is the next step in diagnosing and managing thyroid disease in this patient? One, start treatment immediately since she's certainly hypothyroid with that TSH of 24. B, repeat TSH to confirm that it truly is elevated, and along with that, check a free T4. Or C, hold off on treatment because she's elderly with high blood pressure and levothyroxine will initiate an ischemic coronary event. Well, I think most people would say B, which is the correct answer. And so we do want to repeat a TSH to confirm that it is truly elevated. And along with that, we want to pair it with the thyroid gland hormone, the free T4. So here we're going to go back to our beautiful feedback loop, the hypothalamus, pituitary, and thyroid gland. So the thyroid gland makes mostly T4, about 80%, and about 20% the more potent T3. And these hormones act peripherally on pretty much every tissue in our body, including heart, brain, bone, skin, liver. When the T4 level is high, it will feed back and inhibit TRH and TSH from the pituitary, which will then lead to normalization of T4. If the T4 and T3 levels are low, however, those will stimulate release of TRH and TSH, which then stimulates the thyroid gland to make more T4 to T3. And once that normalizes, then TSH will normalize. However, if the thyroid gland is not normal, then there will be inadequate T4 production and TSH will continue to rise. So when we make our diagnoses, the most common thyroid conditions we're going to be diagnosing include primary hypothyroidism. This is a problem with the thyroid gland. It's usually due to autoimmune thyroid disease called Hashimoto's. And there's a destruction of the gland over time by lymphocytic infiltration. T4 levels decline, eventually T3 declines, and TSH rises. Another common condition is primary hyperthyroidism. So this is a problem at the thyroid where the thyroid gland is producing or releasing too much T4 and T3, and that results in a low TSH. So here you have high T4, high T3, and low TSH. Much less common to the primary hypothyroidism is central hypothyroidism, where there's a problem at the pituitary, whether there's a large pituitary tumor or someone underwent surgery of the pituitary gland, and there's a decrease or loss of TSH producing cells and a low T4. So in this condition, you're going to have low T4, and instead of a high TSH, it's going to be inadequate. So it'll be either be low or normal. Thyroid hormone acts, as we said, on virtually every tissue in the body to alter rates of protein synthesis and substrate turnover. Particularly, you'll see its effects at the cardiovascular level, so it increases beta-1 receptor expression, increases cardiac output, and induces peripheral vasodilatation. It also has central nervous system effects for maturation and function, especially in a fetus, but also in adults and children. It increases metabolic rate and heat production, increases ATP production, oxygen consumption. It has effects on bone development. So we'll talk later, high thyroid levels are adverse for bone, and it affects metabolism of glucose, lipids, and proteins. So the epidemiology of hypothyroidism, it increases with age, females more than males, mostly because autoimmune disease tends to affect females more than males. We'll talk about Hashimoto's in a bit. And if you look at age 85 and over, about 7% of these individuals had overt hypothyroidism. And the prevalence in the general population is about 2%. So there are many signs and symptoms. So here you see the list, but we generally think of hypothyroidism causing a decrease in overall function, decrease in metabolism, effects on heart and muscle, and so fatigue, weakness, cold intolerance, weight gain, muscle aches, paresthesias, constipation, with effects on cardiac output. You can have dyspnea on exertion, depression, dry skin, hoarseness of the voice. And signs on exam, we would see bradycardia and diastolic hypertension from decreased relaxation of the heart. We can see edema, periorbital or puffiness of the face, delayed relaxation of the reflexes, proximal muscle weakness, cognitive dysfunction, especially in the elderly, some sensory loss. This is going to be related to infiltration of aminoglycosides in the around the nerves, is causing a carpal tunnel type symptomatology, coarse skin and hair, and in severe hypothyroidism, you can have third spacing of fluid. In the elderly, the manifestations tend to be less pronounced, and oftentimes symptoms can be attributed to aging and other conditions. And there was one study that looked at 24 clinical symptoms of hypothyroidism in hypothyroid elderly patients over age 70 and hypothyroid younger patients less than 55. And there were fewer signs in the elderly. There was about 6.6 versus the younger group had about 9.3. The elderly were more likely to report fatigue and weakness as a sign, and less frequently reported were cold intolerance, weight gain, and muscle cramps. The laboratory diagnosis of hypothyroidism we went through earlier involves both a free T4 that's low and a TSH that's elevated, usually more than 10. And we do want to confirm this with a second test. Back in the days when we could not measure free T4, which we would have to look at the total T4 or T4 to TBG ratio. And we do not use T3 to diagnose hypothyroidism because it can be normal. In severe cases of hypothyroidism, it will be low, but it also, T3 can be low in normal individuals who don't have hypothyroidism. For instance, if somebody is sick, then you're going to have less conversion of T4 to T3 peripherally. So the peripheral tissues decide how much T3 they need, and they will deiodinate the T4 to make T3. So if someone is sick or fasting, then in those situations, you can actually have low T3 levels and have normal thyroid state. Thyroid antibodies are helpful because they are positive generally in people with autoimmune thyroid disease or Hashimoto's. So those are the thyroid peroxidase and thyroglobulin antibodies. Central hypothyroidism, again, you'll have a low T4 and a normal or low TSH. You'll oftentimes see other pituitary hormone deficiencies with this, and you'll oftentimes have a history of pituitary disease, like tumor or surgery or an infiltrative disorder like sarcoidosis. Not all elevated TSH is true hypothyroidism. So if somebody is recovering from a thyroiditis, a post-viral condition where the thyroid becomes inflamed and releases thyroid hormone, that eventually can lead to a hypothyroid rebound state, which can resolve itself. Recovery from non-thyroidal illness, we'll talk about in the next slide. Very rare resistance to thyroid hormone, so the thyroid hormone receptor doesn't work properly and TSH levels go up to stimulate more T4 production. Rare TSH secreting pituitary tumor, very, very rare, and heterophile antibodies. So if somebody works with mice, they can develop antibodies that crossed over with the TSH assay. If you check a different assay, it'll could be normal. So non-thyroidal illness, euthyroid sick syndrome is another name for it. And so it's difficult to make an initial diagnosis of hypothyroidism in somebody who is critically ill or very sick in the hospital because their TFTs will be affected. So we mentioned earlier that in someone who's who is sick, you're going to have a decreased conversion of T4 to T3 peripherally. So the first thing you'll see is low T3 levels. Teleologically, that's probably meant to preserve your energy to fight infection as opposed to increasing metabolic rates. Eventually, you'll see a low T4 level and then perhaps even a low TSH. So the entire axis starts to decline. If there's a recovery from illness, then these levels all start to normalize and there'll be maybe a rebound in TSH that actually goes above the normal range. And so in this situation, you just want to reevaluate the thyroid axis about 2 to 4 weeks after the illness has resolved to see if these numbers are normalizing. Other labs that may be abnormal in hypothyroidism include cholesterol may be elevated due to reduced clearance. You might see anemia and severe hypothyroidism, myopathy with elevated CPK levels, especially if somebody's taking a statin. That can be pretty profound. Hyponatremia is due to if you have low thyroid hormone, you have inappropriate ADH release and decreased free water excretion by the kidneys. And so correcting the thyroid levels will help to normalize all of these. So we spoke earlier about how thyroid hormone is important for normal cardiac function and vascular resistance. So if you have hypothyroidism in the elderly, these cardiovascular findings were seen. So there's decreased systolic function, decreased diastolic function, increased peripheral vascular resistance, dyslipidemia, and hypertension. So these are all associated with hypothyroidism in the elderly. And the etiology, again, and when you look at individuals over 55, so Hashimoto is made up about 50% of hypothyroidism, 28% were post-surgical, and that could be after surgery for thyroid cancer or thyroid nodules or Graves, after radioactive iodine for hyperthyroidism, and again, infrequent is a pituitary or central cause of hypothyroidism. Again, even less common, amiodarone-induced hypothyroidism, subacute thyroiditis sometimes leads to permanent hypothyroidism. Other causes that weren't in this report from 2002, so we're seeing more and more drug-induced hypothyroidism and hyperthyroidism from immune checkpoint inhibitors, which are used now to treat many different cancers like renal cell cancers, squamous cell cancers, lung cancers, and melanomas. And these include nivolumab, pembrolizumab, and ipilimumab. And so these include PD-1 inhibitors and CTLA-4 inhibitors, and they interfere with the T cell. Normally T cells are inhibited from attacking self, our thyroid glands in our body, via these targets. And so if you have an inhibitor of these targets, you can unleash T cells to now attack cancer, but as a consequence, then you can also attack self. And so you might see hypothyroidism in these patients, in addition to other endocrine conditions as well, like adrenal insufficiency or type 1 diabetes. If someone has had prior external beam radiation for lymphoma, that's also a risk factor for hypothyroidism. Mixed edema coma is the extreme state of severe hypothyroidism in a vulnerable individual that can result in multi-organ failure and a high mortality rate if it's not recognized and treated right away. So the initiating factors can be cold exposure, infection, ischemia. You see it more in females than males because more women have hypothyroidism probably. Clues from our exam, if you don't know that they have hypothyroidism, you might see a thyroidectomy scar, or they may have had prior radioactive iodine. And the signs on exam, you're going to have a depression of the vital signs. So hypothermia, bradycardia, hypoventilation leads to respiratory acidosis, altered mental status, obtundation, coma, and eventually hypotension. The management is admit to the intensive care unit, treat the underlying illness, give intravenous levothyroxine, plus or minus liothyronine, which is T3, and intravenous steroids until we rule out concomitant adrenal insufficiency. So case 2, you have an 82-year-old female with TSH of 6.9 on annual laboratory screening. And so we know that Medicare does cover screening with a TSH in the elderly. Again, it's a common condition in the elderly, and it is supported by Medicare to screen with a TSH. And so we have this mildly elevated TSH in this patient who feels well. She has no change in her weight. She's eating well, regular bowel movements, no cold intolerance, no muscle weakness or pain. She has osteoporosis and she takes alendronate, calcium, vitamin D, high blood pressure, taking valsartan and hydrochloride thiazide. So on exam, she has an elevated blood pressure, a heart rate of 72. She's well appearing, normal thyroid and pulmonary cardiac exam. You repeat her TSH a month later and you find it to be, again, slightly elevated at 7.1, and her free T4 is normal at 1. So what is the next step in this elderly woman with mildly elevated TSH and a normal free T4? So will you follow the TSH and not give her medication? Start levothyroxine now since TSH will likely rise, or start levothyroxine now and make sure she separates it from her calcium carbonate. So the best answer, basically, don't treat the number, treat the person in front of you. She doesn't have any symptoms. Her TSH is mildly elevated, but her free T4 is normal. So this condition is called subclinical hypothyroidism. And for now, we're going to follow her TSH and not give her any medications. So let's look at some of the data about diagnosing hypothyroidism in the elderly. And here you see NHANES data that looked at 13,000 adults in the United States. And the normal TSH ranged from about 0.5 to 5. And this was in individuals who had no thyroid conditions, they're not taking thyroid hormone, no goiter, no thyroid antibodies. So these are individuals without thyroid disease, and this is the reference range of TSH. Now, when you go further and you take a look at the normal TSH based on age, the data starts to be revealing. So the NHANES data stratified individuals based on age and found that the median TSH in the 30 to 39-year-olds was 1.29, and 70 to 79, 1.76, and over 80 was 1.9. So you see a trend up. And the 97.5th percentile for TSH also increased. So it was 3.7, 5.9, and over 80 years of age, it was 7.5. And these are individuals who don't have thyroid disease or thyroid antibodies. And this graph shows you in the TSH range of 4.6 to 5.5, about 3.6% of individuals over 80 fell into that range. If you look at TSH of about 6.6 to 7.5, 1%, 7.6 to 8.5, 1%, and then less than 0.5% in the 9.6 to 10.5. So you can see that in these individuals, as they advance in age, it seems that the TSH reference range might actually be shifting towards the higher range. Another very interesting study was a prospective look at individuals starting at the age of 85. And so it was an observational cohort of 600 people followed until the age of 89. And by that point, 37% had passed away. And so based on TSH, so for every TSH increase of 2.7 above the average, there was a 23% decrease in mortality risk. And again, this is observational, it's not randomized. So, but there does seem to be this association with the higher the TSH, the less risk of death. And those with higher TSH levels, they did not have worsened performance. So their daily life abilities and depression scores and cognition were not affected if they had that higher TSH level. So again, this is a little more data that says that age-specific TSH interpretation may be more appropriate in guiding diagnosis and maybe even treatment decisions in the elderly population, especially the extreme elderly. So going back to our subclinical hypothyroidism patient, she has an elevated TSH and a normal T4. So there is not a lot of strong data for increased morbidity in those with a TSH of 4.5 to 10. There's more evidence if the TSH rises over 10 in terms of cardiovascular disease, lipids, and quality of life. Um, and so, in general, there's no clear evidence that treating subclinical hypothyroidism less than 10 improves any outcomes, except for perhaps reducing progression to overt hypothyroidism. Another study took a look at, does treatment of hypothyroidism, subclinical hypothyroidism in the elderly reduce tiredness? And so here it was a randomized controlled trial, average age of 74. They assigned these patients to 25 or 50 micrograms of levothyroxine versus placebo. The TSH went from an average of 6.4 to 3.6 in the levothyroxine arm and to 5.5 in the placebo arm. And there was no difference in tiredness scores or hypothyroid symptom scores. And so finally, management in these individuals of subclinical hypothyroid, you want to monitor TSH and T4 to assess progression to overt hypothyroidism. And they are at greater risk of progressing if they have positive thyroid antibodies, a family history, or if they have other autoimmune conditions, let's say celiac disease or vitiligo or type 1 diabetes. And if there are symptoms, then sure, you can treat. This is an individualized decision for your patient in front of you. Case 3, so this is a case of Mr. Iodine. He's an 81-year-old World War II veteran who's referred by his geriatrician with a TSH of 45. So he has a long cardiac history. He has a history of coronary artery bypass. He has reduced ejection fraction of 25%, a history of paroxysmal AFib. He used to take amiodarone and it was discontinued 3 months ago. And the only thing out of the ordinary is that he's having increasing dyspnea on exertion. This is a true patient that I saw when I was an endocrine fellow at the VA. So he can't walk as far as he used to without stopping. He doesn't have any weight gain or cold intolerance, muscle weakness, change in hair, skin, or energy. He does have chronic constipation. On exam, you see that he has a mild elevated diastolic blood pressure, no goiter, no nodules. His cardiopulmonary exam, thankfully, is normal. He has no edema. He does have a slow gait and mild delay in the relaxation phase of his reflex. So his TSH is high, it's 45. It was 2.2 before the amiodarone. His T4 is low. His total T4 is also low. So they check both because when I was in training, we're just checking everything and being very academic. His thyroid antibodies were negative. What is this diagnosis? So what does this gentleman have? Well, he has amiodarone-induced hypothyroidism. So we know that a massive iodine load from any cause can shut down thyroid hormone production. This is a normal mechanism called the Wolff-Chaikoff phenomenon, and it's present in order to protect the thyroid gland from taking all that iodine and making thyroid hormone and releasing it and causing hyperthyroidism. So once the thyroid gland equilibrates, it'll go back to making its thyroid hormone, but it won't make excess thyroid hormone. And in so the sources of iodine that can trigger different hypothyroidism or sometimes hyperthyroidism include amiodarone, iodinated contrast, or high dose iodine supplements, concentrated supplements, or kelp. The majority of people, again, will recover from this and resume production of normal thyroid hormone levels. However, if somebody has thyroid antibodies, for like Hashimoto's type antibodies, they are less likely to recover and they may develop permanent hypothyroidism. Amiodarone may also, aside from hypothyroidism, may induce hyperthyroidism if somebody has underlying thyroid autonomy in the form of a multinodular goiter or Graves' hyperthyroidism. So treatment considerations of hypothyroidism in the elderly, we want to start low and go slow in people who are frail, who have low body mass index, cardiac patients. We don't want to necessarily take a weight-based dose. Let's say if somebody had surgery and they had their whole thyroid gland removed, there is a weight-based dose we can use. That's about 1.6 microgram per kilogram for women and 1.7 microgram per kilogram for men. We're not going to use that for the most part. We're going to start with a low dose that's on the order of about 25 to 50 micrograms daily of levothyroxine. This is T4. Remember, the thyroid gland makes mostly T4 and less T3, and that T4 travels peripherally, and each organ will decide how much T3 it needs. T3 is more potent. And the half-life of T4 levothyroxine is increased in the elderly, as are half-lives of many other drugs or hormones. And so there's a longer half-life by about a day and a half or two. And we want to monitor the TSH about every 6 weeks to see what steady state have we reached by giving this T4 dose of, let's say, 50 micrograms daily. If the TSH is still high, then we may increase the dose, but we want to, again, do that very gradually in individuals who are elderly, frail, or cardiac patients. And we want to assess if they're tolerating the dose. So the main symptom I will ask for is, are you having palpitations or skipped beats? That's a symptom of high thyroid hormone at the level of the heart. We want to advise our patients, especially when we first prescribe it, to take it correctly. Take it in the morning with water on an empty stomach and wait about 30 minutes to eat, have breakfast or have coffee or tea. You want to separate it from minerals that can bind it and prevent the absorption, separate it from iron, calcium, magnesium. And if you see that somebody has fluctuating thyroid levels, like their TSH is normal, then it's low, then it's high, oftentimes it's because they're either not taking it every day or because they're taking it incorrectly and the absorption is being affected. And so iatrogenesis with levothyroxine is actually quite common in people over the age of 65. So this study took a look at individuals who were using thyroid hormone, and patients, about 41% actually had low TSH and 16% had high TSH. So low TSH means that they're on too much, probably, and high TSH means they're not on enough. A low body weight was independently associated with a low TSH. So here we are again with our frail, smaller elderly patients. We have to be careful with the dose we start and how aggressively we titrate medication. The elderly may be more prone to over and under treatment with levothyroxine. And levothyroxine in the elderly and effects and associations with fractures. So this was a nested case control study that looked at adults over the age of 70 who took levothyroxine, and they looked at how many who developed fractures. So in about 213,000 individuals using levothyroxine, there was about a 10.4% fracture incidence over 4 years. 88% were women, not surprisingly. Postmenopausal women are more likely to have fractures than men who are elderly. And so current use of levothyroxine actually was associated with higher fracture risk as compared with remote use. And the higher and medium doses were associated with an increased risk of fracture compared with lower doses. And so this is not telling us that thyroid hormone causes fracture, but as we saw in the earlier slide, there's a lot of risk with over and under treatment, and perhaps we're not reaching target goals, and maybe patients are being overtreated and leading to these adverse consequences. So medications that affect thyroid hormone. So we already mentioned minerals, calcium, iron, magnesium. Also proton pump inhibitors will affect absorption of thyroid hormone. Colesevelam, raloxifene soy is common. So if somebody's suddenly eating a lot of soy, they may end up requiring more thyroid hormone dose. Increased metabolism, you'll see with your classic, the older anti-seizure meds like phenytoin, phenobarbital, and also with carbamazepine, rifampin. If a patient has positive PPD and they're being treated with rifampin, they're going to have increased metabolism of their thyroid hormone and require higher doses. If somebody is receiving potent estrogens like birth control, then they'll increase their thyroxine binding globulin and have, if they take thyroid hormone and their TBG goes up, then they'll have less free thyroid hormone circulating, so the thyroid dose needs to be increased. This typically doesn't affect women who take estrogen as a postmenopausal hormone replacement level. Now, just briefly, if somebody's not adherent to thyroid hormone, this very small study of 7 women who were elderly and on a stable dose of thyroid hormone had no heart disease. If that total daily dose was divided into a twice weekly dose, it appeared that it did not affect their peak and trough T4, T3, TSH, or a cardiac tissue factor called systolic time interval. And so if you're really desperate and you need to do directly observed therapy twice weekly, that is an option in these patients. The case number 4, so 87-year-old man with a suppressed TSH of 0.01. He denies palpitations, change in energy, muscle weakness, heat intolerance, dyspnea, hair or skin changes. He has some weight loss of about 10 pounds in 5 months. He takes metoprolol for high blood pressure. So his blood pressure is elevated, 152/70. His heart rate is elevated. He doesn't seem anxious or jittery on exam. He is tachycardic. He has a regular rate and rhythm, but with some premature beats and a hyperdynamic precordium. He has no edema. Thankfully, he has no crackles on lung exam. His thyroid gland is twice normal sized, non-tender. His eye exam is normal. He has no lid lag or stare, and he has no dermopathy on his shins. His reflexes are brisk. So Mr. Tachycardia, on his EKG, he has sinus tachycardia at 120 beats per minute and premature atrial contractions. His TSH is low, as we said, and his T3 is high, as is the T4. We check TSH receptor antibodies, which come back positive at 29. And in fact, he even has a radioactive iodine uptake and scan, which shows a diffuse increased uptake of 52%, with the normal being 10 to 30%. And here you see the example of the thyroid scan, radioactive iodine. So what is the diagnosis? Well, let you think about that for a minute, and let's talk about the clinical presentation of hyperthyroidism in the elderly. So the signs that predominate are actually the adrenergic signs. And so the other symptoms that you might see more in young people, like heat intolerance and um, anxiety and insomnia and um, muscle weakness, they may be less so in the elderly. The elderly are more likely to have sinus tachycardia, atrial fibrillation, systolic hypertension. The adrenergic symptoms are more pronounced, and this is called apathetic hyperthyroidism. The differential diagnosis of hyperthyroidism in the elderly. So the most common cause is a toxic multinodular goiter. And so these individuals usually will present insidiously. It's not like a fulminant hyperthyroid picture, as you can see with Graves' disease, for instance. And so that they'll have these autonomous nodules in the thyroid gland that over time may gain more autonomy and make more thyroid hormone, causing their TSH to go down over time. Less common, but can occur, you can see a solitary toxic nodule that produces too much T4, T3 and causes a low TSH. The elderly also get Graves' disease, which is an autoimmune condition, where there's production of TSH receptor antibody. So this is as if somebody has high levels of TSH. This antibody stimulates the TSH receptor on the thyroid gland to produce too much thyroid hormone. They can have pretty significant levels of T4 and of T3 and T4, usually higher levels than you might see in toxic nodules or in thyroiditis for certain. And there can be eye findings, so you can have proptosis, you can have dysconjugate gaze. There can be a lot of eye findings because of infiltration, fatty infiltration behind the eye, and even fibrosis. And so this can affect the eye muscles, and it can also affect the optic nerve in severe cases. You can also have a dermopathy, so the myxedema, the thickening of the skin, usually of the lower legs. Thyroiditis is a transient condition, so it's not going to cause a permanent hyperthyroidism. It's usually an inflammation of the thyroid gland that's causing release of preformed thyroid hormone that will resolve over time. And so a common cause is subacute thyroiditis. So if somebody has a viral illness, They then can develop an inflammation of the thyroid gland, which tends to be a tender thyroid. They might have mild symptoms of hyperthyroidism, and if you check their labs, you'll see elevated T4, sometimes an elevated T3, and low TSH. So we treat this with using nonsteroidal anti-inflammatories, sometimes with prednisone and beta blockers. And we'll talk more about those in a minute. If you're not certain, then you can do a radioactive iodine scan. If somebody has thyroiditis and they're dumping preformed thyroid hormone, they're not going to be taking up iodine as they would with a toxic nodule or a Graves' disease. So that scan, that functional iodine scan, will be low. After this thyroiditis resolves, most patients will have their hyperthyroidism will become transient hypothyroidism, and then they'll become normal. Sometimes they will become permanently hypothyroid, especially if they have thyroid antibodies for Hashimoto's. So lymphocytic or silent thyroiditis can occur frequently. Might be postpartum, for instance. Exogenous levothyroxine, we saw in an earlier slide that it's quite common to see low TSHs in people who use thyroid hormone, and we have to adjust the dose to avoid this. Iodine-induced hyperthyroidism, we mentioned amiodarone, and so if somebody has an autonomous nodule that's sitting there, or if they have mild Graves' disease, and then you feed those situations with high doses of iodine, you can trigger hyperthyroidism. Very rare TSH-producing pituitary tumor can cause hyperthyroidism. So how are we diagnosing this? So we have a suppressed TSH, elevated T3, elevated T4, and we're going to think about the clinical features. So are there nodules? Is there a large goiter for Graves? Is there a tender thyroid for thyroiditis? Are there eye findings or skin findings of Graves? Was there a recent viral syndrome? What's the pattern of the thyroid level? So has the TSH slowly been getting lower and lower, and to indicate maybe toxic nodules? Or did the person go from normal to abnormal quickly, maybe to indicate Graves or a thyroiditis? So Graves, again, very helpful if you can check a positive TSH receptor antibody in your hyperthyroid patients. About 90% of Graves patients will have positive antibodies in the blood, and then you pretty much have your answer. If you're not certain, you can do a radioactive iodine scan to determine what the etiology is. So here, if you have high uptake, then you're going to, if it's diffuse, that's a Graves hyperthyroid gland where that TSH receptor antibodies stimulating the whole gland to increase thyroid hormone production, to increase iodine uptake, and to increase T4 and T3. If you just have a solitary toxic nodule, you'll have one hot nodule light up and the rest of the thyroid gland will be suppressed. So this situation, this toxic nodule will be making a lot of T4 and T3 and taking up iodine. And because the T4 and T3 is elevated, you have a low TSH and the rest of the gland is suppressed. We had mentioned toxic multinodular goiter, and so here you see that, and this is the most common cause of hyperthyroidism in the elderly. If you have low uptake, then that can be a few things, but thyroiditis we talked about, and again, exogenous thyroid hormone use or exogenous iodine, or if you have ectopic thyroid hormone production in struma ovarii. So treatment, first line, we're going to use beta blockers. Remember, we said that thyroid hormone upregulates the beta adrenergic receptors, and so we have to block those receptors to help lower heart rate and lower blood pressure. So we can use any beta blocker, propranolol, metoprolol, and then we'll also, in situations where you have Graves' disease or toxic nodules, we're going to have to give either anti-thyroid meds or radioactive iodine, or if needed, surgery to treat them. And for sake of time, I'm just going to say that the Graves' disease may remit over time. So if you follow their TSH receptor antibodies and they decline to the normal range, after about a year and a half, the person may be able to come off their anti-thyroid medication completely. If somebody has cardiac disease, we might want to think more strongly about using a more definitive therapy than anti-thyroid meds. So that includes radioactive iodine and surgery. So just briefly, methimazole is first line as an anti-thyroid medication. There's risk of liver toxicity with propylthiouracil. So it is indicated in women in their first trimester because less teratogenic than methimazole, but otherwise methimazole is first line. It works quite quickly. Within days to weeks, there's a decrease in thyroid hormone production. We want to look out for, is there itching or rash? Serious toxicities are not common, but they're a little more common in the elderly and with higher doses. So agranulocytosis, hepatitis, and ANCA-positive vasculitis, rare, but I've seen it. So you want to, when you use antithyroid meds, we're going to be following their T4, their T3. You can also track the TSH, and we're going to look at that white count with the first set of labs, because if agranulocytosis does happen, it tends to happen within the first couple of months. We're going to look at their liver function panel, and we'll adjust the dose based on that T4 and T3. The TSH will lag. So if the TSH is low because T4 and T3 are high, it can take months for that to actually normalize. Now, again, we talked about radioactive iodine as an option in Graves and toxic nodules. If it's used in Graves, it'll oftentimes lead to hypothyroidism, but with the toxic nodule, only those nodules will be affected. The rest of the tissue won't respond, so they may actually be euthyroid after. Surgery, if somebody has a large goiter, if they have mass effect from the goiter, or there's concern of malignancy, they're not tolerating medications, or they either don't want to take radioactive iodine or they have contraindications to it, then you may want to think about surgery. And adjunctive therapies we can use for very hyperthyroid patients. We can use steroids, cholestyramine, and even supersaturated iodine drops. So this is again the Wolff-Chaikoff phenomenon, where you shut down thyroid hormone production, and if they have Graves' disease, it's a dysregulated thyroid gland, you can actually keep that effect, Wolff-Chaikoff effect, ongoing. So Mr. Tachycardia was diagnosed. Remember, he had the high T4 and T3, low TSH, tachycardia, PVCs. So he has Graves' disease because the TSH receptor antibody was positive. And we raised his metoprolol dose, started him on methimazole. We're going to taper it. We'll track his T4 and T3 in a few weeks, as well as LFTs and white count. And then after his thyroid levels settle out, we may actually refer him for radioactive iodine. So if we don't treat hyperthyroidism, there's serious cardiac and bone effects. So we're going to upregulate beta adrenergic effects. So there's an increase in heart rate, an increase in ejection fraction, an increase in cardiac output, also an increase in myocardial oxygen consumption, and a decrease in systemic vascular resistance. So because of the effects on the beta adrenergic effects on heart rate and cardiac myocytes, you have increased risk of AFib, especially after the age of 60. And these patients are at the same risk of thromboembolism and stroke as if it were AFib from non-hyperthyroid. So we do want to anticoagulate these people, or have cardiology assess them for that. These patients, because they have increased oxygen consumption of the heart, they're at increased risk of angina and ischemic events, heart failure, high output cardiac heart failure, cardiomyopathy if they're chronically hyperthyroid and it's not treated. Bone. So bone density will decrease in these patients. There's an increased risk of osteoporosis and fracture risk. And it's not clear that their bone ever truly returns to normal after treatment of the hyperthyroidism. So prior history of hyperthyroidism is a risk factor for hip fracture later on in life. And a hip fracture is one of the causes of excess late mortality if there's previous hyperthyroidism. So again, we want to treat the hyperthyroidism and evaluate bone density, especially in patients who are postmenopausal, or adults over the age of 50. And we want to treat with calcium and vitamin D if they have osteoporosis, and perhaps use a bisphosphonate. Subclinical hyperthyroidism. So this is where you have a low TSH with a normal T4 and T3, and it's usually seen in the elderly with thyroid nodules. Again, there's some autonomy there, and it can be a borderline TSH at the lower limit of normal that eventually becomes overtly low. Mild Graves' disease can cause this, or again, levothyroxine overtreatment, iatrogenic or intentional in patients who have advanced thyroid cancer, who were suppressing their TSH intentionally to help reduce the risk of recurrence. So there's in subclinical hyperthyroidism, there is an increased risk of AFib especially as the TSH gets to less than 0.1 in individuals over the age of 60, the risk is the cumulative incidence is 28% at 10 years. Bone, there's reduced bone density, and we want to work up the etiology of this. We could do a radioactive iodine scan, we could do TSH receptor antibody, and even treat patients with subclinical hyperthyroidism, especially if they're higher risk, if they're elderly, if they're postmenopausal, they have osteoporosis, cardiac disease, or symptoms like palpitations. And if we're not treating, if their TSH just a little bit low and we decide not to treat, then we're just going to continue monitoring them to see if things get worse. Case number 5. So Mrs. N. O'Doul is a 72-year-old woman who's found to have a right-sided thyroid nodule on routine exam. It measures about 2 centimeters in largest diameter. It's mobile and soft. There are no enlarged lymph nodes in the neck. So on the other hand, things that we might be concerned were if this was a very hard nodule, if it was not mobile with swallowing, if it was matted to surrounding tissues, if there were enlarged lymph nodes in the neck, these would be concerning features. She denies any sensation of the nodule. She has no discomfort. She doesn't feel anything when she swallows. She has no trouble swallowing, no dysphonia, no change in her voice. She has no breathing difficulties when she's laying flat, and she has no symptoms of hypothyroidism or hyperthyroidism. And she has no family history of thyroid cancer. She's never had radiation treatment. So, what is the next step in evaluating a thyroid nodule? Should we send her straight to surgery to cut it out? Should we image with a radioactive iodine scan to determine if it's hot or cold? Should we image with a thyroid ultrasound? Image with a CAT scan and give her some iodinated contrast while we're at it? Or check a TSH to determine if the nodule might be toxic? Or should we do both? Image with thyroid ultrasound and check a TSH? So in this situation, the best test to image a nodule would be a thyroid ultrasound. Actually, it's better than a CAT scan. It's the best first line test to look at the size and the features of the thyroid mass. Is it a cyst? Is it a solid nodule? And also, you want to check a TSH, because if indeed the TSH is low, and you have a situation of hyperthyroidism, then that nodule may be the source of that hyperthyroidism. So you do need to know the TSH in this patient. So here, so thyroid nodules increase in prevalence with age. If you look at people over the age of 60 and you do an ultrasound of the thyroid in these individuals, you'll see that about 50% you'll find something on their thyroid ultrasound, whether it's a cyst or a nodule. The majority of thyroid nodules are benign, thankfully. Overall, about 5% do turn out to have thyroid cancer, the majority of which are papillary thyroid cancers. And these thyroid cancers have a good prognosis for the most part if they're surgically resected. People in general do not die of papillary thyroid cancer. There are other cancers of the thyroid, like follicular carcinoma and the medullary thyroid cancer, which is actually a tumor of the C cells of the thyroid, and that those make calcitonin, and that can be seen in patients with MEN2. It's a rare condition. And then we have anaplastic thyroid cancer, which is uniformly fatal, usually within about a year of diagnosis. One of the Supreme Court justices, Rehnquist, actually, this was passed away from anaplastic thyroid cancer. Thankfully, it's very rare. Again, thyroid ultrasound is the best way to image the thyroid gland and to image if you do have a finding on exam. So here you see a normal thyroid gland. Oops. You see the normal thyroid gland, smooth echo texture. You see strap muscles overlying the trachea with the tracheal rings and the large vessels in the neck. Features of the nodule that favor it being benign include if it has an echogenicity that's similar to the rest of the thyroid gland, so it's isoechoic or hyperechoic. If it has well demarcated borders, as you see here, if it has a peripheral rim with vascularity, you'd have to put the Doppler on to see that. Or if it's a simple cyst, meaning it's completely anechoic, these favor benign. Malignancy favored if it's hypoechoic. If there are irregular margins, as you see here, if you put the Doppler on and you see vascularity in the nodule, or if there are microcalcifications that you see here. So by itself, hypoechoic does not mean malignant. There is a scoring system that will add up all these findings. It's called the Thyroid's scoring system for thyroid nodules. It'll help you make a clinical decision whether a nodule is most likely benign. Let's say it's a simple cyst, then you don't need to follow it at all. Or if it has several features that give you a score that's high enough to require monitoring or high enough to require biopsy. So here's the typical evaluation. So thyroid nodule, TSH suppressed, TSH low, again indicating hyperthyroid or subclinical hyperthyroid. The radioactive iodine scan and uptake, if that nodule is hot, autonomous, then you're going to manage this person as hyperthyroidism due to a toxic nodule. Toxic nodules in general are not malignant. And so you would go down this pathway. If the radioactive iodine scan, if the nodule is not hot, then you would just go down this pathway. And this pathway on the left is more common. So if you have a thyroid nodule with a normal TSH or elevated, meaning the person may be hypothyroid, then you're going to do a thyroid ultrasound. And again, you're going to look at the features of the nodule. The Thyroid score is here. So if you have a very low score of 1 or 2, then you don't need to follow the nodule. You don't need to refer for fine needle aspiration. And the higher the score, so if you have a Thyroid score of 5, then you want to refer for fine needle aspiration if the nodule is more than 1 centimeter. Otherwise, you're going to follow these smaller nodules, and in between you have Thyroids 3 and 4. So this is a really helpful classification system that can help guide how to deal with these nodules since they're so common on ultrasound. And so if the thyroid ultrasound is done, and their Thyroid's criteria are say that you meet criteria to do an FNA because there's enough of a risk of malignancy, then you have to decide with the patient. So if the patient has a lot of comorbidities and they have a shortened life expectancy, then maybe we won't refer them for an FNA. But if they decide they want to go ahead with that, then we would, knowing that if it comes back as cancer, we would want to refer for thyroidectomy. So the take-home points, we diagnose hypothyroidism based on clinical features, which are fewer in the elderly, and so we really depend on our labs. And we're going to be looking for a high TSH and a low T4. The TSH is usually over 10. And so again, when you initially diagnose, you're going to be pairing these hormones. You're going to pair the TSH, the central pituitary hormone, with the thyroid hormone or the T4. And again, T3 is not helpful in making the initial diagnosis, as is the TSH with the T4. Subclinical hypothyroidism, if the TSH is elevated, but the T4 is normal, then that is subclinical hypothyroidism. If they have a TSH that's between 5 and 10, we'll oftentimes just monitor TSH and T4 over time without treating, but we can treat if there are symptoms. If they have thyroid antibodies, they're more likely to progress to overt hypothyroidism. There may be a survival advantage of a mildly elevated TSH in the extreme elderly, and the normal TSH reference range may be shifted to higher levels in the elderly. And as of yet, the labs don't give us age reference ranges. If we diagnose hypothyroidism, we want to manage with T4 or levothyroxine, and we want to start with a lower dose and go slow in titration to avoid overtreatment. We want to monitor the TSH. That's the best test that will assess whether the patient's T4 levels are at goal for their individual self. If we overshoot with the levothyroxine, the TSH becomes low, then we want to reduce the levothyroxine dose and continue to follow the TSH. Hyperthyroidism in the elderly tends to present with apathetic features and more adrenergic findings like tachyarrhythmias. We want to diagnose the etiology using the clinical features and labs. So remember that T3 and T4 are high and TSH is low. And you're going to have positive TSH receptor antibodies and Graves. If you are suspecting a toxic nodule or you're not sure what the cause is, you can do a radioactive iodine uptake and scan. Hyperthyroidism increases the risk for osteoporotic fractures, tachyarrhythmias, and heart failure. We're going to manage with beta blockers. And in Graves or toxic nodules, we can use drug therapy like methimazole or more permanent therapy like radioactive iodine and sometimes surgery. Thyroiditis resolves on its own. Again, thyroid nodules are common, evaluate with ultrasound. If the TSH is low, you want to check a radioactive iodine scan and uptake for the functionality of that nodule, because if it is functional or toxic, it does not need to be fine needle aspirated. And the decision to fine needle aspirate a nodule depends on the individual person, the conversation with them. And you'll either follow the nodule or fine needle aspirate it as needed on an individual basis. And that's my presentation for today. I have 5 cases, questions and answers following to help test your knowledge. And I hope this was useful to you. If you have any questions, you can email me at maria.scamagas, SKAMAGAS, @mountsinai.org, spelled out. Thank you.